thanks everyone for joining us. My name is Paxton Bach, and I'm very happy to be here presenting today. Sharon and I will go back and forth through some of these slides, and then do more of a group discussion for the case itself. Before we begin, I just want to say, as one of the co-chairs of this guideline, I'm very grateful to be here today. I'm very excited to be presenting this for the first time publicly, and I'm just enormously thankful for all of the work from the very large group of contributors that has gone into this guideline, from the chairs to the committee to all of the program support. This has been a pretty mammoth effort, and I'm just really thankful for those of you who are on the call who did contribute. And for those otherwise. These are the learning objectives for the didactic session. We're going to describe the key updates to the forthcoming OUD guideline, and I just want to be very clear that the tentative launch date for this guidance will be November 22nd. So this is a preview, but from a regulatory standpoint, we remain bound by our old guidelines until these become official. Secondly, we're going to talk a little bit about some of the clinical guidance changes specifically that are upcoming, including updated titration and induction protocols, and talk a little bit about updated principles of care that we've included in this iteration of the guidelines. So by brief background, I think everyone here is probably pretty familiar with this document on the screen here, the clinical guideline for the management of opioid use disorder, one of the first documents to come out of the BC Center on Substance Use in 2017, really a landmark document in terms of setting the standards for management of opioid use disorder, not just in BC, but in Canada as a whole, and something that I think really had a significant impact on access and on access to treatment for opioid use disorder. However, we're all too well aware that things have changed since 2017, both in terms of our clinical experience as well as the data that informs our practices. So why an update and why now? Well, really, it's about updating our practices to align with the evolving practice changes that we've seen over the past 5 to 6 years, and to review all the new evidence that has been generated over that time to make sure our guidance is as up to date as possible in order to meet the evolving challenges that have resulted from an unregulated toxic drug supply and the unfortunate environment we're all working in today. The process was quite structured and really in keeping with the process whereby any medical guideline is established. So an expert committee was established. There was 3 co-chairs, myself, Emma Garrett, who's on this call, and Dr. Rupi Brar, who some of you may know, a family physician from the downtown east side, were the co-chairs. There was 30 committee members from around the province, including Dr. Vipler. These were physicians, pharmacists, people with living experience, a whole breadth of expertise on the committee itself. And not mentioned here was also external reviewers. So we had an external review panel from all across Canada and the US who also had the opportunity to review and provide input. So a very robust process. The guideline development itself was informed by something called the Agree To tool, which is a structured, standardized way of approaching clinical guidelines. It involved a structured literature search with where we contracted out an individual with expertise in this area, and a grade framework was used was applied to develop and score the recommendations that were made. So all this is a little bit dry, but it's just to say that it's in keeping with the process for the guideline of any for the development of any medical guideline. I'm going to jump right into some of the key clinical changes. So we're going to unpack these a little bit, each one at a time, but just kind of a broad summary here. There's a lot of iterative changes included in this guideline. There's a lot of updates to the clinical guidance in a variety of places, but there are 3 or 4 fairly significant changes that we felt are kind of the key changes worth highlighting today that really will have an immediate impact on clinical practice. And really, these were all intended on addressing some of those key challenges that we face as providers around access and retention to and effectiveness of the care we can provide for the treatment of opioid use disorder. So first of the key changes that we'll talk a little bit about today, and Dr. Vipler will talk about this one, is a reassessment of the way that we have recommended selection of opioid agonist treatment. So many of you may be familiar that the 2017 guideline recommended a first-line buprenorphine, second-line methadone, and introduced for the first time our third-line agent, slow-release oral morphine or Cadian. The update to this guideline with increasing clinical experience, with increasing appreciation for the differences, both in the evidence as well as kind of the clinical reality of prescribing these medications, is that they are different. And we've recommended, rather than a hierarchical approach, really that prescribers work with each individual to determine which medication is most appropriate for them based on their history, their goals, and their preferences. And really the idea here is to try and match somebody with the medication that's going to be effective for them as soon as possible. We'll elaborate on it a little bit. The second item here that we focused on was dosing and titration. I think we're all unfortunately aware that our dosing schemes were never intended on applying in the current era. We've never been faced with a drug supply that's as potent as the one that we are dealing with now, and many of our doses and titration schedules are inadequate to really get people to a treatment dose fast enough to actually retain them in an effective treatment. So we've reevaluated and made some new recommendations as far as dosing and titration goes to try and get people to a clinically stable place as safely and quickly as possible. Third is again a reevaluation of missed dose protocols. The 2017 guidelines were consistent with past guidance in BC around approaches to missed doses, but there are a lot of different approaches across Canada and the US. So we looked at the standards and literature across North America around missed doses and have made some revisions here to try and minimize unnecessary dose reductions that might disrupt treatment and affect people's retention and care, and really put them at risk. And lastly, and perhaps most significantly, there's been a significant change made in the approach to take-home dosing, where slow-release oral morphine is now recommended for take-home doses in the same way that methadone is in appropriate patients, which is new, and the entire approach to accumulating take-home doses has been made far less conservative, and is really quite a pronounced change from very, very restrictive and conservative guidance that predated this guideline. And I will talk a little bit about that and the evidence that informed those decisions. A number of other updates, as I mentioned, there was a pretty comprehensive review and a lot of iterative updates. There's a number of things here that are I think still important additions, including really expanding on principles of care and broad principles for the care of people with opioid use disorder. The inclusion of extended release buprenorphine, which, as most of you are aware, did not exist or at least was not improved in Canada at the time of the 2017 guidelines. Incorporation of iode into these guidelines, that was a standalone guideline prior to here, and we really wanted to incorporate that into this guideline as a evidence-based part of the continuum of care for people with opioid use disorder. There's a whole appendix included here around emergency department buprenorphine inductions, which is new, and really again more detail expanding around continuing care for people who are on opioid agonist therapy. So just to highlight one of those before I turn it over to Dr. Vipler is just expand a little bit on what's meant by principles of care. Really, there's a whole new section to these guidelines that outlines all of these different areas that are important considerations in general for the care of anyone who's seeking care for opioid use or an opioid use disorder. I won't go into any in detail, but you can see that this covers a broad range of topics, everything from inclusion of things like patient-centered care and harm reduction, addressing the social determinants of health, really incorporating trauma and violence-informed practice as a fundamental piece of the care for people seeking help for opioid use disorder. Indigenous cultural safety and humility, anti-racist practices are included and are just an incredibly important part of this guideline and of the care of our patients. So all of this is elaborated on in far greater detail in these guidelines than in past versions, and I hope really helps add just more support for the complexity of this type of care and the importance of focusing beyond just the medications themselves. I won't elaborate on this just for time, but it'll all be there, and we're happy to chat about these more in detail during the Q&A. I will turn it over to Dr. Vipler to talk about some of those more clinical changes.
Thanks. So let's chat in a little bit more detail about the areas that Paxton had highlighted. So starting with selecting OAT medication, and really the idea behind this is that we're moving away from actually ranking OAT medications as first line, second line, third line options. Instead, the guidelines moving towards having clinicians discuss the risks and benefits of all three OAT options, so buprenorphine, methadone, and slow-release oral morphine or Acadian, with the patients and collaborate to choose the medication that's best for the individual based on their preference, treatment history, and other elements that may play a role in decision making. So this is a key departure actually from the 2017 guideline, which recommended that buprenorphine be considered first line or the preferred first line option, while slow release oral morphine in that guideline was introduced as an alternative specialist-led option that really was considered after both buprenorphine and methadone had been trialed without success. Now, many of you are probably sitting here going, well, we've already transitioned our practice to align with this. And I think you'll notice that as a theme. And I think there was a lot of changes that occurred in the context of the learning that we did during COVID. And so while some of this might not seem like a big departure from your current practice, it is a departure from the most recent opioid guidelines that we have. It's important to recognize that this recommendation is not saying that we're equating OAT medications in terms of safety and efficacy, but rather as an intention to offer patients full range of opportunities, options, and facilitate that collaborative patient-partnered approach to care and treatment selection. All right. So moving to dosing and titration, which I think also many of us, started to dabble in during COVID and develop a bit more confidence, but now we have a guidance document to support some of the practice changes that we've already engaged in. So what you'll notice new in this guideline is low dose induction. Many of us refer to this, I think, within our clinical settings as microdosing or micro-inductions. The idea here is that it's the preferred induction for people currently using opioids who don't want to completely stop opioid use prior to induction. And I should be careful with my choice of language. So don't want to stop, or it's impossible to stop, or prefer not to stop. We all know that that's an enormous ask of our patients to be able to stop the use of what's largely fentanyl now for a time period long enough to safely do traditional induction outside of a really controlled setting. It slowly uptitrates small doses of buprenorphine without cessation of other opioids until a therapeutic dose has been reached. In the new guideline, the other change you'll notice is that the maximum dose of buprenorphine has been increased from 24 milligrams to 32 milligrams for both traditional and low dose or micro-inductions. And the sense is that 32 may be reasonable and can be provided safely. We do have safety data on this to address high opioid tolerance in people who use fentanyl and may require doses higher than 24 to get that full day coverage in terms of managing withdrawal and cravings. The other change that you'll notice from a guideline perspective is that the day one maximum dose for a traditional induction has been changed from 12 milligrams to 16 milligrams. Of course, in the inpatient setting, many of you might be seeing practices that exceed that, but this is, guideline based in the outpatient setting. And also this move to encourage people to consider home inductions for any individual who meets take-home dosing criteria. So to really explore the different areas and the areas in where people may feel best supported to engage in these inductions. This is a sample protocol of a micro-induction or a low-dose induction. Really quickly, for those of us who use micro-inductions, and I think that's more and more of us, the loveliest piece of it is it doesn't require a period of withdrawal, which can be very uncomfortable as the understatement of the year for our patients. So it's allowing people to start that process immediately. It may reduce within that context the risk of precipitated withdrawal. It can be started at home or in the clinic, and it can, and I would say that I personally recommend that it's co-prescribed with a full agonist to reduce the reliance on the current toxic drug supply. So moving along to methadone, there's been a slight shift. And again, for those of you on the call that are commonly prescribing OAT, you may be looking at this and saying, well, I've been doing this for a few years. What I would say is now you have a published document to support what you've been doing. So it's the guidelines showing an adjusted guidance for methadone. It'll allow higher starting doses for individuals with higher opioid tolerance, and that's really defined as individuals. One way of defining it is individuals who use fentanyl. The starting dose is going to depend on a number of things: the individual's known opioid tolerance, what they're currently using in terms of opioid use, co-occurring substance use patterns, whether they've had previous experience with methadone or not. For individuals for whom you are uncertain of their tolerance, or it's demonstrated that they have low tolerance, the starting dose is still recommended to be 5 to 10. For those with unknown or moderate tolerance, the suggested starting dose is 10 to 20, and high tolerance is 20 to 30. With very high tolerance, that's moved to 30 to 40. Arguably, in any jurisdiction where fentanyl is present, I think most people will meet that criteria of starting doses of 30 to 40. Moving along in terms of stabilization, and some of you, again, might have been referring to the CAMH guideline that's available, as well as some of the guidance that's available out of Ontario that talks about a process similar to what's being published in these guidelines. So dose increases depend on an individual's known opioid tolerance, and it can increase 5 to 15 milligrams every 3 to 5 days. For those of you who were taught about methadone up titration in the same time that I was, we really were looking at 5 to 10 milligrams every 5 days. So this increases the incremental increase that's permitted, but also decreases the time between increases. And the idea behind that we would ultimately, ideally, be stabilizing individuals on doses faster. If there is, sorry, the chat just popped up for me. If there is a concern about individuals' tolerance level, or there's known lower tolerance, you don't want to be on the higher end of or more aggressive end of up titration. Around 85 milligrams a day, we would recommend slowing it down to a maximum of 10 milligrams every 3 to 5 days. So that more assertive up titration by 15 milligrams is really in that initial stage. And, recognizing that optimal therapeutic doses vary widely from individual to individual. What we have noticed is that that optimal dose has shifted with the introduction of fentanyl into the drug supply, and that doses of 150 milligrams or higher may be required in some individuals to meet their therapeutic goals. Next slide, please. So the new guidance also allows higher slow release oral morphine starting doses for patients with higher opioid tolerance, with a starting dose range of anywhere from 50 to 300 milligrams. I think it's very rare, frankly, for us to be using the 50 to 100, but there are cases in which that would be more appropriate. I think for most of us, the starting dose has probably been around 200. And I know that a number of addiction medicine providers have been initiating people at 300 milligrams, and these guidelines now reflect that ability or support that ability to do so. In terms of high tolerance, we're still saying the 200 milligrams, and very high tolerance, again, being described as individuals who use fentanyl and have previous experience. Higher doses for initiation could be considered with caution on a case-by-case assessment of risks and benefits, and the rationale for higher doses should always be documented, and also ensuring that you've engaged in an informed consent conversation with the patient so they understand what what's being offered and what the perceived benefits are to being offered something that sits outside of guidance or guidelines, but also what the potential risks are, and ideally a conversation about how to best manage those potential risks. Next slide, thank you. The other part around titration. So again, this is a practice that probably most of us have already adopted, but this guideline now is updated to reflect that. So dose increases up to 100 milligrams every 1 to 2 days or 24 to 48 hours. Ideally, the increases should be separated by at least 24 hours. Of course, this is in the context of an outpatient setting, or a setting in which you don't have like regular monitoring. There is, practices in hospital settings or withdrawal management sites that are closed sites in which you could be more assertive, but that's obviously with the assistance of regular medical monitoring. This is in the context of an individual going to take a dose and being evaluated in an outpatient setting. There is no defined maximum dose for slow release oral morphine. Important to note that doses above 1,200 milligrams are often required to manage cravings and withdrawal symptoms. There is a practice change for pharmacists in that the need for open and sprinkling is no longer required, and that it can be provided as a capsule for the patient to take whole. So moving on to mixed dose protocol for buprenorphine. And there's different protocols for buprenorphine depending on if the person has returned to full agonist opioid use or not, and that wasn't a clear delineation in our prior guideline. So for missed doses where the individual has returned to full agonist opioid use, there are a few considerations. So if it's less than 72 hours since the last buprenorphine dose was taken, it's safe to continue buprenorphine without reintroduction or reinduction. Additional factors to consider include the amount of the last buprenorphine dose and the amount and time of the most recent full agonist use. If it's between 72 and 96 hours, you want to sit down with the patient and kind of review the risk of precipitated withdrawal and weigh that against the benefits of continuing buprenorphine as prescribed previously. If it is more than 96 hours, given the potency of the current drug supply, it is a consideration that a new induction may be required. You could use either a low dose micro-induction or a traditional induction protocol based on what best serves the patient you're seeing. Alrighty. If there has been no resumption of full agonist opioid use, if it's less than or equal to 5 days, just continue the medication as at the previous dose. If it is greater than 6 days or more, consider retitration, and it should suit the patient that you're seeing. So whether it's micro-induction or a traditional induction, and how quickly that moves along should be based on what your patient needs and what your patient can accomplish. So as Paxton alluded to, there's been a shift in the missed dose protocol that addresses both methadone and SROM, and I think this is probably an area that perhaps many of us weren't really pushing recently. So perhaps this is practice changing for a number of you. I'm sure that there are individuals that have already started this, but again, rest assured, now there's a document that supports that practice. So the new guideline has modified missed dose protocols. The idea is really minimizing unnecessary dose reductions that may disrupt treatment and affect treatment retention, and further destabilize an individual. So medication can be resumed without change after 3 missed doses, and in most cases, obviously, every time you make this decision, it's a case-by-case assessment. And in line with the new guideline, the dispensing pharmacy can cancel the prescription as well. There is some like fine-tuning work that's being done with our pharmacy colleagues around that, but it'll reflect the guidance. So with the new protocol, if there are 1 to 3 missed days for both methadone and slow-release oral morphine, you resume the same dose, so no change. Up to 3 consecutive once-daily doses can be missed without a dose change, so that on the 4th day since the last dose, the patient can get their same dose. So I just said the same thing 3 different ways because we think this is important. If there are 4 missed days, so 4 consecutive once daily doses, you will have to consider dose reductions, or please consider dose reductions. So for methadone, the script is canceled. There's a reassessment and the dose is restarted at 50% or 30 to 40 milligrams, whichever is higher. So what that means is that on the 5th day, the patient could receive 50% of their dose, or 30 to 40 milligrams, after assessment by the prescriber. For slow release oral morphine, the prescription will be canceled. A reassessment is required, and you can start 50% of the previous dose, or start at an initiation dose, 200, 300, whatever the appropriate initiation dose is for that patient. So for those individuals on the 5th day since the last dose, the person could receive 50% of their dose. So for methadone, not a significant change, a shift of about a day. For SROM, for those individuals that were following the missed dose protocol that was published last, it's a reasonable departure from previous guidelines. All right, and then I'll hand it back to Paxton.
Thank you, Sharon. So I'm gonna cheat here, Emma, for 1 second, because there's one question that came up that I really want to speak to right now, because I think it does contextualize a lot of this. So Brent Nixon was asking about retitrations in the context of somebody who's recently been on very high doses of methadone and now doing a restart, and whether there's acknowledgement of that situation in the guidelines. And the truth is there's not. And the reason that I want to address this right now is that these guidelines are a summary of the most up-to-date literature that we could find in all of these areas. And the reality is that literature is quite scant, and there is essentially no published research out there from anywhere that we could find in the world discussing higher starting doses of methadone than 40 milligrams, and even that is rather few and far between. That's the reason why we settled on 40, even though it's been very clear that from groups of people who lived in living experience, that still felt to be a subtherapeutic starting dose. So I think there's still I say this for 2 reasons. I think there's still lots of work to be done here in terms of research and developing more nuance in the way we approach these things. But secondly, both for Cadian and for methadone, there's an acknowledgement, and the best we could do is an acknowledgement that if there's a feeling based on your clinical judgment that a faster titration is warranted, that's something that that any clinician can choose to proceed with, but to do so with an abundance of caution and just be really thoughtful both in your discussion with patients as well as the documentation. And I would never do that unless you had a lot of clinical expertise in this area. So there is a recognition that clinical judgment is encouraged, but this is the most aggressive recommendations we can make that we can confidently say are safe and are based in the literature. And I think it's really important to keep that in mind, because a lot of you will be looking at this and thinking it still feels like it's not enough. I think collectively these changes will be a significant difference, but I agree. I think there's a lot more work that needs to be done in this area. So with that, I'm going to talk about the last piece of change here, and one that I think is quite impactful, and then we can get into our case. The last thing that we're going to be talking about here, and probably one that to me at least is going to result in some of the biggest changes in practice, is a review of how we're providing take-home dosing. Now, much of the changes that we've talked about thus far have been based on mostly kind of established, basing most on clinical experience and expertise from our group around the province, and practices that have been evolving over some years. This is the one recommendation that I think is most firmly grounded in quite a significant amount of new evidence. One of the realities, I suppose I'm not going to call it a silver lining because that's far too generous, but one of the realities of the COVID-19 pandemic is that guidance around take-home doses changed quite abruptly and quite dramatically in Canada and the US. In order to help promote self-isolation, and that has resulted in a considerable amount of research around more liberal take-home dose practices in both the Canadian and US context. It is very clear that travel to a pharmacy for daily witness ingestion it can be a significant barrier to retention and engagement for many patients. It is very consistently identified as one of the highest reasons for attrition and for lack of interest in OAT. And we know that quick transitions to take-home buprenorphine naloxone improve adherence and retention of the medication. So we did a pretty thorough review of the evidence that came out in the context of COVID-19 to reevaluate similar recommendations around full agonists such as methadone and Cadian. I won't get into a thorough summary of it. A lot of it is in the guideline. I'm more than happy to talk about this. But there was a recent Lancet paper in Lancet Public Health, some of you may be familiar with. It was this meta-analysis or systematic review of US studies alone. And there was 29 different studies from all across the US outlining perceived benefits from patients and providers related to increased flexibility in take-home doses. And we have some pretty good Canadian research as well, suggesting that patient retention was as good or better. Patient quality of life was markedly improved, and there was no evidence of any increased overdose rates. So that is what led us to, sorry, next slide, I can't switch it here. Go back one. So yeah, so that's what led us to reevaluate our take-home dosing recommendations. As I think take-home buprenorphine has been the norm in most places for some time, but again, as Dr. Vipler highlighted, this is now very well established in our guidelines themselves that take-home dosing for buprenorphine can begin as soon as day one for anyone who has the clinical stability to take care of their medications and to take them regularly and to store them safely. Really, that is the only significant feature around take-home dosing of buprenorphine, and I think that this is already pretty well established in current practice. But take-home dosing for methadone and for Cadian, if we go to the next slide, has changed quite dramatically. Our recommendations here have obviously been highly conservative for many years, and in the context of the new evidence that has emerged from COVID-19. And I should also point out, in close collaboration with Ontario, Medify Ontario, some of you may be familiar, actually issued identical guidance, and there's been out for about 2 months now. So these changes were made in close consultation with Medify Ontario, and we've aligned our recommendations to be more or less identical. That take-home doses for methadone and sororities or morphine can start in patients who have been on medications for as short a time as 4 weeks, as long as they are on a reasonably stable dose and have demonstrated the capacity to be able to be consistent in their dosing and safe in the way they take it and can store it safely. Take-home dosing has been aligned for methadone, sororities, or morphine. Anyone who can be considered after 4 weeks at a reasonably stable dose, regardless of whether they're continuing to use substances or not, that is not the only factor to consider any longer. They'll start with individual non-consecutive doses, and every 1 to 2 weeks can accumulate further non-consecutive doses. After 12 weeks and demonstrated safety and consistency with non-consecutive dosing, they can begin to qualify for consecutive take-home doses. If we can go to the next slide, this is articulated in a table here. So again, not a candidate, somebody who's either just initiating the medications, who is not able to safely store them, because these are medications that can cause significant harm if opioid naive patients end up taking them. Very significant acute psychiatric illness or other acute mental health crises that would again prevent somebody from safely being able to take their medications regularly. Frequent missed doses or frequent missed appointments may be a factor in deciding candidacy, and well as really high risk or uncontrolled substance use patterns, overdoses, blackouts, uncontrolled use. There's some clinical judgment there. As soon as somebody has been on a dose for 4 weeks and is on a reasonably stable dose, has demonstrated an ability to safely store the medication, has been quite consistent in taking the medication, and has the clinical and psychosocial stability that's felt to that they can safely manage these medications, that they can begin to qualify for those non-consecutive doses. And by 12 weeks, once they've have had non-consecutive doses for a period of time, they've been on medication at a stable dose for 12 weeks, and are demonstrating again that increased consistency in terms of their medication adherence, ongoing improvement in the clinical and psychosocial stability, can begin to qualify for consecutive take-home doses as well. You will note that abstinence at no point here is considered one of the key metrics for qualifying for doses. Really, it's more related to general clinical and psychosocial stability and stability in your substance use, such that it's not felt that this would put you or others around you in danger. So a fair amount of room for clinical discretion. I will say that these are fleshed out much more detail in the appendices of the guideline, because I think this is going to take some time for people to wrap their heads around. And Medify Ontario has put out some really excellent documents here, again, summarizing the background literature and really providing case scenarios as to what each of these things look like. So I highly recommend that anyone who's interested look up the documents that are publicly available from Medify Ontario, again, for a bit more expansion on this. And I'm happy to talk about this at length. So just in summary, some of the key updates in the 2023 opioid use disorder guideline will be moving away from a ranking of OAT medication, incorporation of low-dose induction guidance from buprenorphine and naloxone for those who would benefit from an alternative induction mechanism, modified maximum starting doses and titration protocols, especially for full agonists, simplified guidance for missed doses of these medications, more relaxed protocols for provision of take-home doses, still quite rigid and quite restrictive, I will say, but much more, I think, realistic than past guidance, and a much greater emphasis on the principles of care.